some of the following slides, I've just provided some printable desk prompts that you can have handy either in your pocket or at your workstation to better assist you with selecting billing codes. And one portion of several of the desk prompts includes the level of service based on medical decision making. And I think it's very important to review these levels of service um, and understand what it means to be a low, moderate, or medium or high level of service based on medical decision making. And some of this has changed with the new guidelines for 2021. So just a quick review of levels of service based on medical decision making. In order to meet any level of service, either a 2, 3, 4, or 5, you must check 2 of the 3 boxes within that row. And what I mean by that is when you're assessing how much medical decision making goes into the patient visit, you are looking at 3 areas: the problems addressed, the data reviewed, or the complexity of the patient, and then the risks of the plan of care or the treatment. So say you are considering this to be a level 4 or medium or moderate level of service, within that you must meet the criteria of 2 of the 3 boxes across that row. So looking across that, if you have a patient who comes in with 2 or more stable chronic conditions, or one chronic condition with an exacerbation requiring the treatment or addressing that exacerbation, you've met that criteria for a level 4 problem. And say you are only reviewing results from unique tests or something along those lines, and that level 3, you're not making the level 2 data reviewed, but your treatment is a prescription management, so that risk is a level 4 risk. It falls under that row of that level 4 prescription management treatment for the exacerbation, let's say. That has met the requirements for a level 4 or a moderate or medium medical decision making. So especially for new providers, or if you're in a different area of practice, it's really important to review how you determine the level of medical decision making and support whether this is a low, moderate, or high level of service to support your billing codes. Here I have included some desk prompts for you to have for the outpatient E&M visit. These are your 99202 for new patients through 99205 and 99211 through 99215 for an established patient. And I've included a separate little prompt in case you just need reminders specifically for the new guidelines when you're utilizing time alone. But all of that data is here in the larger chart for outpatient E&M visits. And just as a reminder, that 99201 code has been removed. So for a nurse visit, they must be an established patient, but for a nurse visit to be coded as that 99211. And I do discuss separately the nurse visit billing and coding in a separate discussion, so please view that if you have any questions on nurse visit billing specifically. But what I wanted to mostly touch on just briefly is just recalling that there are times that it's appropriate to use time alone to support your billing code. And then there are times when it is appropriate and necessary to rely on that medical decision making to be the support for your higher level of billing code. And one example of that being say you see a patient who's established with your practice and they are just coming in for a medication follow-up. It's a brief visit. The patient is doing well. You review their chart. You go on to the state website to ensure that they haven't, say for example, the patient is on Adderall and they haven't been prescribed medication elsewhere. It's perhaps, a 20-minute visit, which would fall under the 99213 category. However, you're still prescribing Adderall, so that risk does go up to a 99214. And in this case, that 20-minute visit, you would not want to use time to support a 99213 because your risk is higher. Your risk is increasing that level of service from a level 3 to a level 4 visit. And I can't emphasize enough how easy it is to undervalue and undercode your your the level of medical decision making, the level of skill you're using, the risk involved with the patient visit, with the patient encounter. So if you are a new provider, especially, I think it's important to take a brief moment and truly look at how much medical decision making complexity and risk is involved with the encounter, and don't solely rely on either how comfortable you are with that type of patient you're seeing or the brief amount of time you may take for the visit, but really give credit to the amount of complexity and decision making and risk involved before you choose that billing code. Here we have some inpatient coding desk prompts. Feel free to use these. I have them separated both by observation and observation with discharge, as well as office and inpatient consults. So you'll see that chart there on the left. If you're a consulting provider, say you are in urology, for example, and you consult on a patient in an office setting, you will follow these 9924X. However, if you are in urology and you are consulting on a patient on the floor, the billing codes that you will select are 9925X for the consult time. So just note that there are some differences there between the two, office versus inpatient consults. And then over here on the right are some prompts for the E&M coding for admission, for the initial admission, as well as progress notes. So perhaps you are on the service of the team caring for the patient who was admitted. You may not have done the initial admission H&P. However, you may be monitoring the patient's progress, and these are typically the progress note E&M codes that you will follow. And again, they're going to follow the same structure as any of our other patient encounters based on the history, the exam, the amount of time you spent with the patient. I do want to say the caveat to this being critical care. And for those of you who are seeing patients in critical care, I know we don't have many in our organization right now, but we do know that for those patients specifically, you must document your time with the patient and note how much time was spent with the patient as far as coordinating care and educating the patient. So